Good evening, everybody. I'd like to share with you how iStent Inject fits into my glaucoma management. And these are my disclosures. This is the scope of my talk. I would like to sum up how the last 5 years of using the iStent Inject has influenced and changed my glaucoma management. Simply, I will look at it from the angle of the needs of the glaucoma patient and how the type of glaucoma affects its usage. Glaucoma medications have been instrumental in protecting glaucoma patients' vision, but it has certainly come with issues such as orbital or cutaneous side effects, ocular surface disease, dry eyes, and also issues related to non-compliance. MIGS likewise have issues too, such as implant obstruction, surgical morbidity, and not to mention costs. On balance, I would argue that MIGS bear serious consideration for our patients when it comes to glaucoma management options. For example, reducing the glaucoma medication burden would certainly avoid cutaneous side effects, such as the contact dermatitis seen above. This allergic reaction to brimonidine tartrate has been reported in up to 25% of those treated. More recently, the side effect spotlight has shifted to the prostaglandin class of glaucoma drugs. On the top, you can see the prostaglandin-associated periorbitopathy in both eyes of this patient. When prostaglandins are used unilaterally, like in the example below, the cosmetic issue can be stark. In my glaucoma practice, combined phaco-MIGS is the majority by far of MIGS cases that I perform. This is a schema I use in my management when considering what to do for a glaucoma patient with a significant cataract who is undergoing cataract surgery. What concurrent glaucoma procedure should I also offer them to consider? I use the number of glaucoma medications that they are on to help decide. At a basic level, only the phaco might be performed with all glaucoma medications continued post-operatively. The next level offered is combining the cataract surgery with trabecular bypass drainage for patients stable on one glaucoma drop. The upside is a high certainty of discontinuing the one drop. For those on 2 glaucoma drops, there is a possibility that they can be drop-free too. Trabecular bypass drainage can also be considered for patients on 3 or more glaucoma drops if the aim is to reduce the overall medication burden and patients are prepared to accept continuing some but less glaucoma medications post-operatively. The alternative offering is subconjunctival MIGS for patients on 2 or more glaucoma drops, which comes with it different issues, but a higher chance to be medication-free. Next, let's consider the influence of the type of glaucoma on my glaucoma management. At the beginning of my 20 years of ophthalmology practice, this would have been the surgical procedures performed. Trabeculectomies and tubes for primary open-angle glaucoma, trabeculectomy for normal tension glaucoma, and cataract surgery, trabeculectomy, tubes, and goniosynculisis for primary angle closure glaucoma. Then in the last 5 years, the MIGS revolution entered my practice. And now my surgical management looks more like this. Trabecular meshwork bypass mix and subconjunctival mix are now options for primary open-angle glaucoma, normal tension glaucoma, and even primary angle closure glaucoma. For the purposes of today's talk, I will focus on trabecular meshwork bypass mix when discussing their application and relate it to the type of glaucoma. As you know, iStent implantation can be performed as a standalone or combined procedure, and even toric intraocular lens implantations are not impacted by the procedure. For those less familiar with the procedure, let me show you a quick video. In this 2022 case, the Schlemm's canal is easily visible from the blood blush. To get good separation between the iStent injectW stents, it is common now to shift the microscope and seating to facilitate wider spacing between the implants. In Singapore, iStent is on label for use in primary open-angle glaucoma, both standalone use or in combination with cataract surgery. Let me share with you our results in primary open-angle glaucoma in combination with cataract surgery. This is a paper we recently published looking at the safety and efficacy of the iStent inject in combination with phacoemulsification in Asian eyes with primary open-angle glaucoma. It was a retrospective study, and the outcome measures included best corrected visual acuity, intraocular pressure, number of glaucoma medications, and surgical complications. There were 95 eyes. Most subjects were male, Chinese, and the mean age of subjects was 74 years. The mean preoperative intraocular pressure was 16.2, and the mean number of glaucoma medications was 1.9. This table shows you the mean postoperative intraocular pressure and mean postoperative number of medications at different time points from postoperative day 1 to postoperative month 12. On the two rightmost columns are the mean intraocular pressure difference and mean medication difference at various time points compared to baseline. All these differences were statistically significant at all time points between postoperative day 1 and postoperative month 12. At postoperative month 12, the mean intraocular pressure difference was 1.3 and mean medication difference was 1.4. At the 12-month period, 70.8% of eyes were medication-free. We had some complications. Intraoperatively, one eye developed malignant glaucoma. Postoperatively, we had 2 implants obstructed by iris. 1 case of visual acuity drop due to glaucoma affecting the central field, and 1 case of cystoid macular edema. In conclusion, there was a statistically significant and sustained reduction in intraocular pressure and number of glaucoma medications up to 12 months postoperatively. This with a favorable safety profile. Having started with on-label use in primary open-angle glaucoma and finding satisfactory results, we then started using it in normal tension glaucoma cases, but with the aim to reduce the medication burden. Let me share with you our results. Initially, we did a retrospective study to evaluate the safety and efficacy of the iStent inject device combined with phacoemulsification in eyes with normal tension glaucoma up to 12 months after surgery. The outcome measures we looked at included best corrected visual acuity, intraocular pressure, number of glaucoma medications, and surgical complications. We looked at 91 eyes undergoing surgery. The majority of subjects were male and Chinese, and the mean age was 73.2 years. Preoperatively, the mean intraocular pressure was 14.3, and the mean number of medications was 1.5. This figure shows the mean intraocular pressure at baseline and at each postoperative time point from postoperative day 1 to postoperative year 1. Significant intraocular pressure reduction was observed at all time points except postoperative week 1 and postoperative month 12. Of interest, the number of medications was reduced at all time points. By postoperative month 12, there was a reduction of 1.2 medications compared to baseline. In terms of complications, postoperatively, there was 7.7% of implants obstructed by iris. 1.1% had IOP spikes at postoperative month 1, and these were due to steroid response. And 2.2% of cases had postoperative hyphema. So our conclusion was that combined phacoemulsification and iStent inject surgery resulted in a statistically significant and sustained reduction in intraocular pressure up to 6 months postoperatively and reduced the number of glaucoma medications up to 12 months postoperatively with a favorable safety profile. In light of the promising results in normal tension glaucoma with iStent inject, we investigated it again prospectively. This is our recently published prospective 1-year study. Similarly, this was to evaluate the 12-month surgical outcomes of combined iStent inject implantation and phacoemulsification in Asian eyes with normal tension glaucoma. And this was a prospective single-center case series of 30 eyes followed up until 12 months after surgery. Our outcome measures were best corrected visual acuity, intraocular pressure, number of glaucoma medications, and surgical complications. The majority of subjects were Chinese, and the mean age was 73. Preoperatively, the mean intraocular pressure was 13.8, and the mean number of medications was 1.3. This figure shows the postoperative change in mean intraocular pressure. There was a statistically significant reduction in intraocular pressure from postoperative month 3 onwards. Concurrently, there was a statistically significant reduction in the mean number of medications compared to baseline from postoperative day 1 onwards, with a mean decrease of 1 medication by postoperative month 12. Also, by postoperative month 12, 83.3% of eyes were medication-free. In terms of complications, postoperatively, there was 10% of implants obstructed by iris. There's also 6.7% of cases with an intraocular pressure spike at postoperative month 1. 3.3% of cases also had postoperative hyphema. Yet again, we concluded that for combined phacoemulsification and iStent inject surgery for normal tension glaucoma patients, there was a statistically significant and sustained reduction in intraocular pressure and glaucoma medications up to 12 months post-operatively. Over time, As experience and confidence grew in performing the surgical procedure, I also used it off-label for primary angle closure glaucoma cases in combination with cataract surgery. In reviewing the literature, both the iStent G1 and iStent inject, or G2, have been reported used in angle closure glaucoma with efficacy in lowering intraocular pressure and glaucoma medications. Let me share with you a case to illustrate iStent inject use in angle closure. The patient was a 72-year-old Chinese female who had primary angle closure glaucoma and was on 4 glaucoma medications. She was post-laser peripheral iridotomy, but still phakic with a nuclear sclerotic 2+ cataract. Her pre-operative intraocular pressure was 12, and she was listed for right eye phaco intraocular lens implantation, goniosynechololysis, and iStent inject implantation. This video starts after cataract extraction and intraocular lens implantation. As the angles were closed all around preoperatively, a single mirror gonio lens was used to evaluate the angle opening after cataract extraction alone. As the angles were still not fully open, goniosynechololysis was performed using viscoelastic in all 4 quadrants. Gonioscopy was repeated to confirm angle opening. In the superior nasal angle, the viscoelastic cannula was used to expose Schlemm's canal better by gently pressing down the iris. Thereafter, the iStent procedure could proceed, and 2 implants were injected into the nasal angle. Good blood reflux could be seen. At the postoperative month 1 visit, her intraocular pressure was 15 of all previous 4 glaucoma medications. Of course, such off-label use is controversial, and I accept that it is open to debate what results I may have obtained had I only done a phaco or phaco and iStent inject implantation without goniosynechololysis. But this is an illustration of how we could possibly go the whole 9 yards with combined mixed surgery without resulting to more invasive glaucoma surgery. Let me wrap up this talk by summarizing. In my practice, I consider MIGS, particularly the iStent inject, an attractive alternative to glaucoma medication use. Reducing the medication burden reduces side effect and also the morbidity from non-compliance. My practice has pivoted to using the iStent inject in normal tension glaucoma and angle closure glaucoma, in addition to primary open angle glaucoma. Likewise, I believe the ophthalmic literature is evolving to support these clinical practices. I would like to wish you well in your glaucoma practice. May we better meet the needs of our patients. I'd just like to acknowledge the great glaucoma team I have at Tan Tock Seng Hospital, Singapore. Thank you for your attention.
Thank you very much for that, Dr. Yip. I'd like to now I might just say we might hold questions to the very end and just do a bit of panel discussion once both presentations are done. The Q&A box is open, so if you want to put your questions into there, we'll come back and address them all after Dr. Chu finishes his presentation. Okay. So Dr. Shenton Chu is a refractive cataract and glaucoma surgeon who works at Auckland Eye and Auckland counties. I'm sorry, I can't see. Manukau's district health boards. He received training in all currently available MIGS devices during his 2-year glaucoma fellowship at Moorfields Eye Hospital. He advocates for his patients and colleagues through his roles as a spokesperson for RANZCO and as a chair of the Auckland District Health Board Ophthalmic Surgeons Committee. And tonight, Shenton will be speaking about how his personal results compares to the peer-reviewed literature. Thank you.
Okay, thanks for the introduction, Melody. Let me know if there's any issues on your end presentation-wise. Now, my brief is to go through some of the relevant literature and then add in my personal experience. And I thought that was an excellent presentation from Leonard, and it certainly was stimulating for me personally as well. So I'd first like to recap with what I see my goal as a glaucoma subspecialist actually is. You know, is it to lower IOP or perhaps to prevent visual field progression? Well, stepping back a bit, my goal really is to maintain the quality of life for my patients. And I do this by preventing visual disability, by keeping my patients seeing in some capacity, at least throughout their lifetime. You know, I think we all have that sense of morbid satisfaction when our patients have reached their end and you look at their chart and you think, you know what, they could see something to the end. We've done some good here. Additionally, in New Zealand, the public transportation infrastructure is extremely weak. And this means that we're incredibly reliant on driving, and therefore one of the things I specifically go through with my patients is that a real goal is to keep them legal for driving from a binocular visual field standpoint for as long as possible. And we need to achieve this without causing excess side effects from our treatments, something I go through with people I'm training, the optometrists that might be managing glaucoma in the community, really is to consider wisely before commencing something like an eye drop, which is lifelong and can cause significant burden, especially in someone who might not even need it, who has ocular hypertension, which is primary, or perhaps just as a glaucoma suspect. So our traditional incisional surgeries are powerful, but they have significant risks. And our eye drops do cause a huge amount of unrecognized ocular surface compromise. We've got a bleb-related endophthalmitis in the photograph on the top there. And on the bottom, for those of you who can see that little superior iridectomy, this patient's had a trabeculectomy, which really highlights what Leonard was talking about, which is this prostaglandin-associated periorbitopathy in this patient's left eye. And is probably likely is on bimatoprost. So just as an anecdote, again, what I train my registrars to do is to sort of avoid that particular prostaglandin analog as much as possible, because you're already thinking 10 steps ahead as a glaucoma specialist. What if there's no option? We need to take on trabeculectomy being the most powerful surgery. We need to have the eye in as good a condition as possible to achieve success, not failure. So it's far rarer to have treatment options that allow us to achieve both improved quality of life by preventing visual disability and minimizing treatment burden. Selective laser trabeculoplasty is one that does come to mind, but the iStent devices certainly fall into this category. And it really is impressive that this device now has a significant database. And as Melody mentioned in the introduction, the number of implanted devices is now, in fact, over 1 million worldwide. So let's run through some of the relevant literature, starting with efficacy. So this was a pivotal trial, and a pivotal trial is one that is often required for regulatory approval, and thus it's rigorously designed to ensure that a treatment is both safe and efficacious. And this one by the Samuelson group compared iStent and Inject plus phaco to phaco alone in over 500 patients. And that was a 3-to-1 randomization, so more in the iStent arm. And this looked at patients out to 24 months, and it showed that there was definitely a higher percentage of patients that reached a 20% of reduction in unmedicated intraocular pressure in that iStent arm, and that these patients had about a 7 millimeter mercury reduction in their intraocular pressure, and really that a fairly impressive drop in mean intraocular pressure from 25 down to 17 millimeters of mercury. And additionally, as we sort of know anecdotally, it confirmed that the iStent component, in addition to the phaco, had no significant increase in complications compared to phaco alone. There's a good question we can come to in the Q&A later on about convincing a patient for standalone surgery, but certainly in a combined setting, it's a very simple consent process to say no additional risk on top of what we're already doing, and makes a lot of sense while we're there, so that we don't double up that tiny risk that a cataract surgery entails with a second intraocular procedure in the future. I mean, a lot of people or a lot of us are trained to be skeptical until long-term data proves a therapy. And there is an increasing amount of long-term data that does confirm ongoing intraocular pressure and medication reduction, with 16 studies now out to 4 to 8 years of follow-up. One of the other questions I think that has come up is, well, what's the story with this trend to less intraocular pressure reduction with time and less medication reduction? Well, I think if you followed any procedure that we do in glaucoma, this is going to be the natural trend, be it even trabeculectomy or tube shunt surgery, and whether that's the progressive nature of the disease, some component of treatment failure, I think it's all in the mix. If we knew we had a procedure that got an IOP of 10, lasted for their lifetime and took 10 minutes to do, then I think we'd be out of a job and would never need to see our patients again. But we all know well and good, doesn't matter how good our treatments are. One of the main things we tell our patients is how important ongoing follow-up really is. Out of these longer term studies, this one had an impressive size cohort of over 400 patients out to 6 years. And interestingly, there seemed to be a greater reduction in intraocular pressure in this grey group, which is the moderate severity of glaucoma. Anecdotally, I wonder if this is due to this particular cohort or sub-cohort having patients with higher untreated or higher peak intraocular pressures, as I've found that the higher this is, the greater the potential reduction can be. Now, there is less robust evidence comparing different trabecular bypass style MIGS surgeries. Things in the same space would be the Hydrus implant, the Cohook dual blade, and it really is quite a competitive area for these companies, which is to our patients' benefit and to our benefit, because the cost part of the equation is important to consider in terms of both the public and private setting that I work at, and I'm sure where you guys work as well. Data has been presented by our respected colleagues from independent data sets, such as the Fight Glaucoma Blindness Registry in Australia, showing an edge to iStent. And from a personal point of view, technically, I do find iStent implantation to be the most straightforward and repeatable, though I would not underestimate the learning curve required to really achieve perfect placement and optimum results, just like any surgery that we do. And while the bulk of the evidence is geared towards the IOP data and control, there is evidence for things like visual field preservation as well. But of particular interest to me is the growing body of quality of life literature. It's pleasing to see that there have now been demonstrated improvements to things like ocular surface disease metrics. So OSD scores are better, mean fluorescein breakup tear times better, conjunctival and corneal staining is better, conjunctival hyperemia is better at 3 months, things that we knew should happen with decreased treatment burden, but good to have in the literature. And it's particularly evident in the cohort of patients who have severe ocular surface symptoms preoperatively, with this group benefiting tremendously by the 3-month mark, presumably related to being on multiple medications once again. And with my refractive hat on, we know that the iStent is a refractively neutral device compared to solar cataract surgery. So it's not going to impact on things like what Leonard mentioned, your toric lens implantation, even possibly a premium or lifestyle intraocular lens that you may deem suitable in someone without really established and significant glaucomatous optic neuropathy who's earlier or is an ocular hypertensive. But we know that the tear film is really critical in refractive stability and quality of vision and quality of life. And therefore it's unsurprising to me, but nice to know that we've now got this quality data to confirm improvements in indices such as general vision and driving. And what flows on from that is improvements in the more global quality scores. So improvement in the general health scores, ocular pain scores. So moving on to some of my personal data. So this is not published. This is just real world data from a case series of patients that I made one of my fellows help collate for me. And so these are patients who underwent combined cataract surgery and iStent implantation. You can see from the peak intraocular pressure readings that these are high pressure glaucoma cases predominantly, listing pressure sort of better on treatment, obviously. And it was really pleasing to me to see a sustained intraocular pressure reduction. To be honest, the 1 month time point's often a bit of a red herring because there can be an element of steroid response depending on your postoperative regime. But when you're seeing, figures sub 14 millimeters mercury by 12 months compared to their listing and peak pressures, it's really pleasing. And what you need to realize is that in terms of glaucoma severity, while the iStent is sort of suggested and recommended on label for mild to moderate glaucoma, because of the safety profile of the device, a lot of these patients would have had more severe or advanced disease. So it wasn't that my goal was necessarily to reduce medication burden, but it was as an adjunct, because I was worried about possible disease progression. For example, imagine that patient in front of you, quite a significant field defect. Is that getting worse? Could it be that medial opacity that's affecting the global metrics on the visual field? Could it be that there's some glaucoma progression? Intraocular pressure is not too bad, maybe a little bit borderline. Do I really want to go for something more significant like trabeculectomy or tube shunt surgery? No, this is a great option in those patients to clear up any artifact in the visual field in case there is some progression, and it's been useful for me personally in that cohort. And despite including these patients, there's still a significant reduction in the number of medications from 2.1 down to 1.3. And as I said, my goal wasn't necessarily to get them off meds, but certainly, as sort of Leonard alluded to, if they've got an earlier neuropathy, they're only on 1 or 2 medications, then washing them out completely and giving them a medication-free trial is always useful. And it's something that we might forget to do if that wasn't necessarily your goal or the patient's expectation at the outset of the surgery, that you have to remind yourself, okay, it's safe to wash out, let's see what happens. And just a bit more about the case mix of this series. As I mentioned, most of it was high pressure glaucoma, so your primary open angle glaucoma, acute exfoliative patients, just primary ocular hypertension, one uveitic glaucoma patient snuck in there, and there was a series or a handful of primary angle closure patients and normal tension glaucoma patients as well. So it was interesting to hear some of that published literature from Leonard, because you know what, it would be reasonable to be skeptical about the performance of iStents in subgroups like primary angle closure, because really it's going to be difficult to know how much IOP reduction is from the phaco alone compared to the phaco plus the iStent. And with the NTG group, you can always argue that you're limited by episcleral venous pressure. So it's going to be difficult to get your IOP lower than 8 to 10 millimeters of mercury. And what if their peak pressure was 12 to 14 millimeters of mercury? So it was interesting to hear some of that data, and it depends on the case mix of what's prevalent in your communities as well as to where this device and your entire surgical schema is geared towards. And so look, if you exclude those two subgroups, the data is still pretty good in my case series, and that everything's pretty similar, still around about 14 millimeters of mercury out to 1 year, still a good reduction in medication burden as well. So in terms of wrapping things up, I think sometimes picking out a couple of cases gives you a better flavor of the real world performance and value of these devices in some situations. And for example, here's a patient, 70 years old, comes in, first appointment, reduced vision, 621 best spectacle corrected from cataract, pseudoexfoliation noted, and an elevated intraocular pressure. And thankfully for this person, no glaucomatous optic neuropathy clinically or on OCT scanning of their periapapillary retinal nerve fiber layer analysis and ganglion cell layer analysis. And again, we know that this is not an Oates style primary ocular hypertension patient. This is not one that we'd want to just sit on. It's one that we want to lower pressure in, because they have a much higher chance of going on to get glaucoma and bad glaucoma at that. And so instead of starting any treatment to lower pressure, I went straight to phaco with implantation at that stage with 2 G1 iStents, so the original first iteration, which some would argue have a slightly more challenging implantation technique to them. And the patient had a great result, 6.6 unaided, pressure controlled, 17 millimeters of mercury. And the cool thing is that she never touched a glaucoma drop and didn't even need SLT, which would have been another reasonable consideration. And ever since the LIGHT trial, which showed us the efficacy and safety of SLT, I feel that drops have certainly lowered down and down the pecking order, and things like iStent are closely hot on the heels. And so with this patient with acute exfoliation background, I do feel that conditions like this, which lead to a resistance to outflow at the trabecular meshwork level, can do very well with trabecular bypass stents. It sort of makes sense from a physiologic point of view, and real world wise, it works. Things like maybe pigment dispersion might be another one, but again, there's going to be more technical challenge there. Deep myopic eyes, you can imagine what a phaco is like. Those are not the best cases to get started with in terms of your first iStent implantations when it's all about good gonioscopic view. So I mentioned the trabecular bypass sort of block. Well, this is also the case for my next patient, who was a steroid responder, which is also thought to be due to a trabecular obstruction mechanism. So this guy, he had a background of chronic idiopathic anterior uveitis, and he was being managed by our uveitis subspecialty team. And what was happening was he was getting recurrent flares of his anterior segment inflammation requiring steroid treatment. And this is what the red arrows are, is when he got hit with prednisolone acetate 1%. And you can see the the big spikes in the IOP from this treatment. And, again, stepping back, when you're managing your uveitic glaucomas, it's a difficult group. You're trying to work out what's the main driver of the IOP rise. Is it a steroid response? Have they come in without any steroid treatment and their pressure's already up? Is their peripheral anterior synechia causing a secondary angle closure mechanism? And in this situation, he didn't have PAS, but what he was getting was bad posterior subcapsular cataract blocking his vision to count fingers. Unfortunately, I had OCT scanning on him to know that the health of his nerve was reasonable. I could still see around that central posterior subcapsular lens opacity to assess the optic disc, and I knew that his optic nerve was hanging in there, and that because of the cataract, we could consider something like a phaco iStent. Now, I listed him for that, and funnily enough, he turns up to our pre-assessment clinic, so the assessment just before surgery, to consent, confirm biometry, execute all the surgical plan and medical plans, and he had the highest pressure I'd ever seen for him, which was almost 50. And I think I'd probably caused that, because one of the things we do in these situations with any uveitic undergoing phaco is we look to control the inflammation. So I might have had him on increased topical steroid, maybe even oral steroid to boot. And so at this visit, I was obviously concerned that the surgery that we decided on was going to be underpowered. And I talked to him about changing to something like a phaco tube, or even potentially you could go for a trabeculectomy if the inflammation has been controlled. And in my hands, I'd leave the cataract till later. But he's obviously was dead keen on getting his cataract done with the count fingers vision, and he liked the risk profile of the iStent. So I was happy enough to proceed, on the caveat that if we ran into problems in the early post-operative period, we'd need to do an urgent tube to sort that out. And he did far better than I anticipated. We did the phaco iStents, his pressures dropped down, and then here's when we needed to add in more steroid for rebound anterior segment inflammation, and amazingly, it didn't really spike up, and I'd see him quite quickly afterwards, because I was just expecting that this wouldn't be the case. But thankfully for him, it worked incredibly well. So I hope that's sort of given you a flavour of what to expect in a real-world setting with your iStent device implantation, comparing that to the evidence base that's out there, which is increasing almost day by day and year by year. And again, thanks for your attention. I hope that you've found some of that content interesting, and look forward to answering some of the questions.
Thank you, Shenton. That was an excellent presentation. Dr. Yip, going to join us. We do have quite a few questions. Can we just start with Dr. Yip? Do you consult your patients the same way in those different cohorts, or do you talk to them about different expectations? So your POAG, your normal tension and your angle closure.
I would say that I generally consult them the open angles like the POAG and NTG in a similar way, in that I would give my advice based on the number of medication that they need currently, assuming that the intraocular pressures are currently well controlled, and it's mainly that they are needing a cataract surgery and whether to do something adjunctively at the same time. But for the angle closures, I think the discussion it gets a bit more involved, because obviously it's off-label, and then it also depends whether you think that you can actually do the surgery. For example, what would be very important is whether preoperatively the angle is already just narrow, or is it absolutely completely closed, and whether you can indent it open. So in those cases where the angle is closed and cannot be indented open. And yet I would just give them a more guarded advice that we would do the cataract surgery and then see whether we can open up the angle. And if we can, and the angle structures are well organized still, then we can proceed with the iStent. So that's the slight difference when it comes to angle closure.
And Shenton, do you do anything different?
No, not so much, but I just following on from that, more of a question from me to Leonard, which I thought was sort of interesting, is in terms of goniosyneculitis, you can argue pros and cons about its value. Certainly in the acute setting, there's no question, right? An acute symptomatic presentation of primary angle closure where you're removing the lens, but are you quite an advocate in the chronic primary angle closure presentation where there's established PAS? And then is that because you believe that there's going to be better potential outflow through Schlemms, or is it in this sort of situation more so that you can visualize the implantation site for your iStent?
Yeah, thanks for the question, Shenton. So I would say that I'm not an advocate for always doing a goniosyneculitis, a complete 361, I mean. But obviously, where it comes to putting in iStent into the nasal angle, it would make sense to do your utmost to improve your visualization in the angle after cataract surgery, and to use viscoelastic to facilitate that. So in that aspect, of course, that nasal angle has to be opened up if you want to put the iStents there. The example I was giving was more the extreme where I thought I was trying to stretch the use of an iStent to someone on 4 drops. That's quite a stretch, you must say. So of course, that was just an extreme example where I'm saying I'm going in the whole 9 yards to do my utmost for the patient to try and get them off their drops. So I just want to increase their chance by opening up all 4 angles. So that's where I'm coming from with the goniosyneculitis. So I wouldn't say I'm a diehard goniosyneculitis person, but that's just the whole 9 yards.
And I guess back to your question, Melody, I guess if I was to implant in more patients with normal tension glaucoma, it's the same discussion that I'd have with any treatments that I was starting in this cohort, and that it's very difficult, or I try and steer them away from intraocular pressure, the numerical change, because it fluctuates, right? I'm not going to bring a patient in for phasing before and after every treatment I carry out for an MTG patient. And this is a proper low pressure patient, not someone who may be high normal. And so it's about being realistic to say, we know that treatment X is effective in this condition, in pressure reduction. The risk profile is acceptable. And if we're there and you want me to do that for you, certainly I've got no problems doing that. Can I hand on my heart say that this is going to be a game changer? No. And if your disease is progressing rapidly, I may say probably not, in my opinion. But that's the sort of discussion how that might go.
Thank you. So while we're still talking about setting expectations, there was a question that you alluded to earlier that came from the attendees. So how do you then talk to patients who are undergoing standalone in terms of setting their expectations? Who wants to take that one? Dr. Yip, you want to go first?
Okay, I'll have a go. I must say that in my practice, doing standalone iStent injects are the minority, because obviously it is a surgical procedure. In those cases, I would say that they would tend to be cases where the intraocular pressure is not well controlled, and they are looking for alternative options to addition of more medication. For example, if they are already allergic to one bromidine, for example, or to BAK, for example, and where perhaps SLT has been tried and failed and things like that. So
in these cases, it's of course, then it's much easier to convince the patient that this is a viable approach for them. So I think these would be the more common use cases in my practice for standalone, those who are looking for medication reduction or already need more medication but running out of options, or other options such as SLT have failed.
The only thing I'd add to that is you've really got to be a believer yourself before you can convince a patient, if you will. So for me, as I sort of alluded to during my talk, I'd be extremely reluctant at my stage to be on, I always round up to 100 when I'm talking to a patient. So let's say I'm on 60 more years of eye drops. That's someone's really got to twist my arm and prove to me that I need that treatment. It's for me to commit to that, let alone be compliant to it for all the other reasons, and that all glaucoma treatments don't really have any positive feedback. It's just reassurance that what they're doing is important. And so in this sort of situation, it's our block to say, well, entering an eye does carry risk, and we don't want to belittle that this is a surgery. It's not something to be sniffed at. It carries significant but rare complications. But then you've got to really balance the other side, which is 40 years of drops, not just the inconvenience, the side effects, the potentially more difficult surgeries later on. And this is where SLT is certainly an easier discussion, because without that entering an eye philosophy, which is maybe more our issue than our patients, that's sort of going to be most people's fallback stance. But even if that's how you choose to go, I think just entertaining that idea, well, what would the next step be? What would I really want? What would I want my family to have? It becomes easier to then consider a standalone MIGS, and especially because we know the efficacy is there and the safety profile is good. But I think when you're on your journey, you'll certainly start with combines because it's much easier discussion from all parties.
I'm sorry, Mel, you're on mute.
I'm sorry. There is a question here around combined surgery. Like, when do you implant the stents, before or after you remove the cataract?
Yeah, for myself, I routinely put the stents after cataract surgery. And usually it would be before viscoelastic removal from the bag. I like to leave my viscoelastic in my bag when I'm doing my iStent, just to keep the eye a bit firmer and more controlled. So that's my preference. Of course, the other option obviously that is to put it at the start of surgery. But it's always nice to have a wider angle to work with, and in my view. And there's always greater safety putting it at the end, because say you have a unfortunate complication during your cataract surgery, a posterior capsule rupture, and there's substantial vitreous loss. It may change the case of whether you want to put in the stents under those circumstances. So after would be a very safe option in my view.
Yeah, I'm also an after phaco implanter, though interestingly, having supervised some cases which didn't go so well from a phaco point of view, the fellow was a pre-phaco implanter. So I was sort of glad that the stents were already in, because we wouldn't have put them in had we gone through all the rigmarole of anterior vitrectomy and that. But I'd still advocate for after, but it does sort of depend on your comfort, because it really is dependent on how good your view is. And, for example, you've got a first-year trainee doing an hour-long phaco. The cornea is not going to look so great, and maybe the before phaco has some benefit there. But for me personally, the blood in Schlemm's canal is a great landmark. Having more fluctuations in the intraocular pressure during your surgeries promotes blood to reflux in as a landing site. If you are in a population where you've got shallower anterior chamber depths, then, as Leonard says, it's actually going to be technically easier afterwards, as long as your view is good. And the other thing view-wise is that if you like to create your incisions more limbal to be less refractively significant, and you catch a limbal blood vessel, there's more time for that to close off if you do it after your phaco as well. So that blood won't seep in under your gonio prism, which will do much worse than a little bit of mild main incision edema.
I'm sorry, Mel, you're on mute again.
Sorry, we are on time. We're at time, but we've got one more question that I'd like you to both answer before you go away. There's a question here. Great presentations, and thank you for sharing your experience. Faced with patients undergoing cataract surgery with mild to moderate glaucoma, is there any reason why you wouldn't offer a mix to all these patients? And if so, why? Shenton, you want to go first?
The only reason why I might not have in the past is if a non-glaucoma, let's rephrase that, a non-iStent implanting cataract surgeon has done the other eye and they're on drops. And what am I looking to do if I'm looking to reduce treatment burden in one eye? It's not really going to help because they've still got the inconvenience and side effect profile in the other eye, right? So that's probably the only time I would have been like, well, I'm not really going to achieve the quality of life benefit for you. But then if you were able to, funding-wise or patient buy-in-wise, you can always just go and do pseudophakic stents in the other eye. So even that small group is possibly not. And then in someone who's got the potential to rapidly progress, for example, they might be moderate, but they might have an underlying diagnosis, which means they're not going to do well, or they need something more robust in terms of pressure lowering amount, or like a tube, for example.
I think for me, it would not be so much their glaucoma per se, but really whether they were on other systemic treatments, for example. I'm quite cautious about patients who are on these new novel oral anticoagulants, for example, apixaban, where they're used as substitutes. For warfarin, for those on atrial fibrillation, they can be really quite serious and severe sources of bleeding from angle MIGS. And I would be a bit more cautious about offering it to these patients. The other group that I can be a bit more cautious with patients who are on renal dialysis, because of during the dialysis, for example, they may get heparin in the infusion line during the dialysis, and it's possible to have quite severe bleeding during the dialysis into the angle, and I've been burnt in one case. So these are the two main situations where I would be a bit more cautious about doing angle MIGS.
Thank you. Actually, can I just ask one more question? Because I think it's an important one that would relate to quite a lot of markets and countries that are on the line at the moment. It's a question here about many patients paying out of their own pocket for MIGS. And so how do you explain to a patient the benefits of iStent surgery so that they're comfortable to pay out of pocket? Shenton, you want to go at that?
Yeah, look, I think it's similar to what I've said already. It's just that frank and open discussion about the pros and cons of each thing. And if I saw that they were getting, drop allergy is easy, right? The drop allergy, drop comes out. Drop intolerance is more tricky. It's a spectrum. And when you see that the drops are causing problems and you want to get them off the drop, then it becomes much easier to sort of be stronger in what your recommendations are. Because frankly, a lot of patients I see that are on multiple agents, if you really looked at them and maybe even looked at their passport photos from pre-treatment, they've got an unacceptable level of drop intolerance that they've just got used to, and their family and friends have got used to over years of treatment. It's just because it's such a subtle and chronic thing. So I guess in that group, it might be easier. And someone who's completely okay on drops, then yeah, that's fine. That's their decision. At least I've given them the option. My problem is when the option's not given to them because their surgery is done by someone who can't do it, right? So it's like when you're in the public sector and your registrar doesn't offer a premium intraocular lens solution, and you find out that they're desperate to reduce their spectacle dependence. Just because you don't offer it and you don't know how to do it doesn't mean that you shouldn't. That it doesn't need to be discussed. It must be, right? And that's sort of the main take home from my point of view there, is that they need to know that these options are there. At the end of the day, it's up to them cost benefit wise as to whether they want to proceed.
I might ask you one last different question, Dr. Yip, and that's what do you do to ensure the view is maximised? And what do you do if the view is not clear after numerous attempts?
Well, this of course refers to iStent implantation. So
correct, yes.
The keys are really firstly good angulation of the microscope and of course of the eye itself, and that is probably key to the whole visualization. It's necessary to try to get the trabecular meshwork as on face as possible when trying to do implantation, and that's probably not appreciated enough. Sometimes we live with suboptimal angulations where the trabecular meshwork is still a bit tilted. The other thing is, of course, just taking the time to at a macro level, adjust your microscope well. That means, I'm not sure if it's very well taught, but we're never really told how to focus the microscope without the gonio lens on. And what I always do is I will shift my microscope first to focus on the distal iris and get into focus first before I put the gonio lens on. And then I would always ensure that my microscope is well centered in the view, and all these things do help improve the view. Like Shenton was saying earlier on, I guess key would be to try and minimize corneal swelling during the phacoemulsification, particularly at the limbus nearer to yourself. So yeah, do whatever you need to try and make the cornea as least swollen as possible, even if you have to use a soft shell technique or that sort of thing. Put more dispersive viscoelastic to protect the endothelium, so that you have a better view at the point that you want to do your iStent inject. So these things would I think would be key to a good visualization. Of course, there are also many gonio lenses now available, commercial ones as well, those from Glaucos. And I think you should choose the one that you think provides you the best handling and the best view in your hands. So do try out many lenses, all the gonio lenses, and see which one is best and provides the best view in your hand.
Okay, well, thank you. I think we might stop it there. We just want to say thank you to Shenton and Dr. Yip, and obviously for everyone who's stayed on with us to the very end. Have a very good evening. Thank you.